Okay, this is Chapter 35, Emergencies for Patients with Special Challenges. So we're going to talk about a variety of different challenges that might be faced by patients. We're going to talk about types of disabilities. We'll talk about how that affects pre-hospital care for these patients. We'll talk a little bit about some specific congenital and acquired diseases. We'll talk about some advanced medical devices, and we'll talk about abuse and neglect. So, general categories of special challenges. So, a disability is just some condition that interferes with your ability to do your normal daily activities, daily life. So these can be either developmental disabilities, so the congenital or genetic things like cerebral palsy or Down syndrome, or they can be the result of some injury or medical condition suffered later in life. So MS, Parkinson's, stroke, traumatic spinal cord injuries, these kinds of things can also cause special challenges or disabilities. So a terminal illness is something where you're going to die from that illness in the near-ish future, right? So end-stage cancers, heart failures, kidney failures, and other progressive fatal diseases. And so these folks might need some kind of technology to keep them alive. They'll often have some advanced directives, whether they do or do not want CPR performed, and they might have some special emotional needs. Obesity is an ongoing epidemic in the United States. This increases the risk of many things. So diabetes, heart disease, hypertension are all have a significant correlation with obesity. So for the significantly extremely obese patients, we need special equipment, but some other just basic things. Make sure that the patient is going to be sitting up most of the time. These patients really don't do well laying fully supine with the mass of all that on their lungs. Make sure you have enough people when you're lifting or moving them. Don't be afraid to call for some extra help if you find yourself without enough people. Homelessness and poverty are often associated with mental illness and disabilities. These folks have a hard time keeping a steady job, perhaps, and so also problems associated with that are malnutrition, drug abuse problems, perhaps, other communicable diseases like HIV, AIDS, tuberculosis, pneumonia. All these things associated with a poor living conditions, and Okay, we're going to talk about autism a bit here. So the incidence of autism has gone up markedly, especially in the last 15 or so years. Some of this can be attributed to better diagnoses, but certainly not all of it. So it's not well understood why this increase is occurring, but it certainly is. Autism occurs in all racial, ethnic, and socioeconomic groups. More common in boys than among girls for some reason. So when you're dealing with autistic patients, we'll use this acronym ABCS, and what that stands for is the awareness, basic, calm, and safe. So we'll go through each of these. So first is just the awareness, and that is basically just realizing that you need to do things a little differently with an autistic patient. So these patients really won't handle disruption of their normal routine well. It can be difficult to talk to them, and not keeping things calm enough and kind of forcing issues can lead to escalations or meltdowns, which is like an involuntary tantrum, and that's not going to make the transport any easier or quicker. So keep things basic. So whatever you're telling them, instructions need to be real simple, very clear, and just real precise. So normally we like open-ended questions, so questions like describe your pain, that kind of thing. With these folks, it's best to have a short question and closed-ended. So, does your head hurt? Yes, no. Does your whatever hurt? Yes, no. That kind of thing. We don't need to be bringing in a whole bunch of equipment if it's not necessary, so just keep it to what you need to bring in. Try and keep the scene as calm and not chaotic as possible. If you have the option to defer something, go ahead and defer whatever treatment if you can. Be calm. If you yourself are calm, then it's more likely that they'll stay calm. So one-on-one is best. Don't overwhelm somebody with 3 and 4 responders or more, all trying to be in the same room and interact. Be empathetic, be compassionate, take a little extra time. Unless there's some life-threatening emergency, you can take a little extra time with these patients. Try and keep the environment around them as safe, identifiably safe to the patient as you can. So, if they're in their own house, in their own room, that's good. If anything makes them particularly upset, then remove that thing. Like with kids, with these patients, we want to do a toe-to-head survey instead of a head-to-toe, and just do it one step at a time. This isn't going to be a 30-second assessment. It's going to take a little more time here. If you need to take breaks during the exam, then take a little break and do something else for a sec. If you can, let the patient kind of control the flow here a little bit and let them tell you when they're ready for the next step. Okay, so we'll talk about some general considerations now. So advanced medical devices are getting further and further out from the hospital, so not only in the hospital and in the ICUs, NICUs, that kind of thing, but out into nursing homes and into private residences. And so the caregivers out there might be nurses in home care provided by nurses. They might be just friends or family, but they should have been trained on whatever device is there. And if they're calling you, then they've probably exhausted their knowledge of it. But you should always ask and see if they know how to fix stuff. Some people will assume you're an expert on everything. The patients themselves are often pretty knowledgeable as to their condition and what's going on, and how to fix problems with machines and that kind of thing, as they've lived through it, right? So do what you need to do to take your time and care for these patients. If you've got a problem with an advanced medical device, first, is that problem life-threatening? Yes, no. If yes, then go ahead and transport pretty quickly. Do you have the knowledge to fix the problem? Probably not. Do you have the supplies? Probably not. Is it within your protocols? Almost certainly not. So don't spend a lot of time unseen trying to fix something that you're not qualified to fix. Some more specific diseases and conditions here. Again, we're going to lump things into the congenital versus the acquired. Patients have these conditions often for a long time, but that doesn't mean that these chronic diseases can't have an acute experience with them there. And other illnesses that a patient develops can be pretty severe just due to the not having as a healthy baseline as other folks. So you might find folks on a variety of home respiratory devices, so like a CPAP device, tracheostomy tubes, and home ventilators. We'll talk about these. So a CPAP device is a continuous positive airway pressure device, and basically keeps the pressure of in your lungs up beyond normal atmospheric at all times. So it basically just doesn't let you breathe out all the way. And this keeps the little alveoli inflated and can be prescribed for a variety of conditions. These things are not the difference between the patient breathing and not breathing. And so you're probably not being called for problems related to the machine itself. If they want to bring their CPAP machine to the hospital, that usually should be allowed. You might just mention that to ER staff when you're calling in. Tracheostomy tubes. So this is a surgical opening in the neck. The little port adapter there is a standard size, so you should be able to hook up a standard BVM to that. Some complications, you might have mucus buildup or otherwise need to suction that tube, which you can do with one of the French suction catheters. The patient may or may not be able to speak with that tracheostomy tube in there. So what you need to do for these folks, check the tube. If it's clogged, again, use a French catheter to suction it. If you need to ventilate with a bag valve mask, then go ahead and do that. These patients should most likely be sitting up if possible. Home ventilators. Basically with these things, make sure your tubes are all clear, that it's connected to oxygen. If you're transporting the patient with one of these ventilators, just make sure that it's securely strapped into the ambulance somewhere so you don't have something banging around injuring EMTs or patients if the ambulance happens to get in an accident. We'll talk about a couple of cardiac devices, pacemakers, automatic implanted cardiac defibrillators, and LVADs, or left ventricular assist devices. So pacemakers are implanted, and they do just that. They act as the pacemaker for the heart if the heart isn't able to do it on its own anymore. So that's what it can look like there. As the scar in this patient's also had some open heart surgery at some point. So the rhythm on the monitor is going to look different depending on the variety of the pacer, but you'll see little vertical bars, sometimes a lot taller than the ones here, and that's the pacemaker going off, and then you'll see the QRS complexes after the little bars there. more or less for these pacemakers, we can treat them just about like any other patient. So we can do CPR, we can hook up defibrillators to them, and it doesn't affect our treatment much. Automatic defibrillators that are implanted, so they're not super common, but we do encounter these things. And it's just like what it sounds like. It's a defibrillator that patient is wearing all the time, implanted. So if it detects a fibrillation, then it's going to go ahead and defibrillate immediately, which is something the patient can definitely feel, described as feel like being kicked in the chest, good and hard. So the shock isn't dangerous to you as a provider, but the patient is going to feel it. So realize that if you get called to a patient where that thing is going off, that patient would be laying on the floor in cardiac arrest had they not had that device. So that's the level of seriousness you should treat that call. So you probably want to call ALS. Again, that's a high-risk cardiac patient. Give them oxygen. They need frequent reassessment. If they do go into a cardiac arrest, despite their device, you can use regular CPR and AED pretty much as normal. LVADs, or left ventricular assist devices. So this is a mechanical pump that moves blood around the patient's body. So this is kind of what a modern one of these things look like. The pump is implanted. The battery pack and controls for it are going to be outside the body. So for us, if there's an issue with the machine, there should be some documentation with the patient at all times. Go ahead and call the provider and see if they can provide you some more information on what you can do to fix any immediate issues. So the devices can tolerate a battery swap when they're live. They'll often also have an AC cord that you can plug in. There may or may not be any kind of manual backup for these things. Make sure that you're securing the battery is to not pull on the tubing excessively. CPR is okay for these folks, so you can do CPR if necessary. Gastrourinary devices, so a few things in this category: feeding tubes, urinary catheters, and ostomy bags. Mostly your role is to just not pull them out. Don't pull out feeding tubes, urinary catheters, or ostomy bags. So there's a picture of a feeding tube. For some medical reasons, and people can't take stuff orally, and so this is how they'll get their nutrition. There's another example of a feeding tube. So if the tube isn't secured already with some kind of tape, then secure it. Keep the bag of nutrients higher than the patient, a little bit higher than that tube. If you're not going to have the food bag on there, then put that little protective cap in place. Urinary catheters, this is something we encounter pretty frequently. Lots of people do this at home now. So you'll find folks like this. During transport, keep the bag lower than the patient. Don't put it on the floor, but just hang it off the off the gurney. If you notice urine discoloration, you can note that. We don't really empty these bags. If you do empty it for some reason, document the amount. Ostomy bags are kind of the same thing as a urinary bag, except for feces. So this is going to be hooked up to an intestine. may or may not be visible through clothing. Some common problems here: infections, blockage, or dislodgement. So again, your goal here is to just not pull that thing out. Dialysis. So folks that are having kidney failure or renal failure need to undergo dialysis. So there's two main forms here: hemodialysis and peritoneal dialysis. So in hemodialysis, their blood is essentially shunted out into a machine to clean and then go back into the body. So they actually hook up an artery and kind of pump it out of the machine and then back into the vein. And that thing is a fistula. So these patients are going to be doing this multiple times a week for a few hours at a time. And then there is peritoneal dialysis, where you float fluid through the abdomen, and that fluid collects waste that way. And so that can take about 20-30 minutes for one of those things to go, and the whole process would be a few hours. So again, hemodialysis is usually performed at a dialysis center. Some complications from that: maybe bleeding from the fistula, infection at the sites. Peritoneal dialysis, complications here can be dislodging of the catheter, or general infections of the abdominal cavity, that peritonitis. So your goal here, again, not pull anything out. Don't do blood pressures on the arm with those shunts or fistulas, any of that tubing sticking out of that arm. Just avoid that arm for blood pressures. These things are directly tied into arteries, so if you damage any of that tubing, that's going to be a significant blood loss event. You're probably going to need a tourniquet to control it. If direct pressure doesn't stop it. Treat for shock, transport. Another thing you might find on patients out there is central IV catheters. So folks that have not well controlled diabetes, other things where they're going to need IV pretty frequently, things like chemotherapy, stuff like that. They may have a long-term IV catheter placed. So some complications there, again, infection at the site. Again, we just don't pull them out and we don't use them. Don't pull it out. Other general physical impairments. Any of our normal senses can be impaired: hearing, sight, speech. Some folks have trouble walking or standing. Remember that any kind of physical impairment doesn't mean mental impairment. Provide any necessary assistance. If you need extra help lifting, get extra help. Try and figure out whether this is baseline or new, depending on what impairment you're looking at. Figure out what it is that you need to do to keep these folks comfortable. Explain what you're doing. Bring whatever they need with them to the hospital. Okay. Abuse and neglect. So patients with special needs are dependent on care from others, and so they are vulnerable to abuse. So these patients can be children, they can be adults. Adults may be especially vulnerable. So look for stories that are inconsistent with their injuries. Look for multiple injuries. in various stages of healing, indicating that they've been injured repeatedly. If caregivers are indifferent to the patient, that can be a sign of abuse. Don't make accusations. Do transport. Do document things objectively and thoroughly, and report any suspicions of abuse onto law enforcement and or the hospital staff. So in cases of abuse and neglect, just be especially careful to document really well, and not destroy any potential evidence too. And that's the end.